just watching on the screen here in the studio, looks like the Senate is getting sort of configured there, Rhino, to take a vote, pass the bill. Now, what happens after that when it goes to conference? Who knows at this point? But we're pleased to welcome now Leah Smith, General Counsel and Vice President for Policy and Advocacy for the Mississippi Hospital Association. Hey, Leah, thanks for coming in.
Good morning. I'm so glad to be here.
All right, so we're glad to have you. So a lot of provisions in the big, beautiful bill, all 940 pages of it. It did shrink when it came from the House. It was over 1,000 pages. It's now below the 1,000-page mark. But much of the provisions of this bill, outside of all the various tax language, concern health care. That's something that affects your members, the members of the Mississippi Hospital Association, the hospitals not only in Mississippi, but, of course, across the country. So I'm sure your members, your organization, you're watching this closely, and there's some things you guys are concerned about.
We do have some concerns, and we've been talking to the delegation. And look, I just want to start by saying they've been great. This is my first year on federal advocacy with the Hospital Association, and the number one thing I want to say is our staffers up in D.C. are amazing. They're polite, and they do all the right things in that regard, but they're also so knowledgeable. And so we have been back and forth and talking to them, and there have been things that have changed in the bill, even in the Senate, from the Senate Finance Committee language that was really problematic, that have changed since then because of our advice and because of our conversations. So I think the first thing we would want to say is just thank you.
Okay.
Beyond that, we have some different concerns. The bill, really does impact expansion states more. So you've got some
Medicaid expansion.
That's right.
Of which we're not one. There are 10 that have not expanded. We're one that hasn't.
That's right. So those states that have expanded for able-bodied adults, those are the ones that are going to see some real big pinches. But we have some too. And top of the list is our state-directed payment program. So the way that the bill reads currently, which it is changing, I think the parliamentarian right now is looking at handwritten changes. So
it just passed, by the way, in the Senate. It literally just announced.
It did?
What was as drafted just announced.
Okay. Well,
literally just happened while we're sitting here. I'm watching on the screen.
Well, I'm very hopeful that we're going to be talking about the right provisions because we don't really know. But that being said, what was in the bill about a half an hour ago when I read it?
Okay.
Was some provisions that would take our state-directed payment program rate down from the average commercial rate to 110% of the Medicare rate starting in 2028. That's better than the Senate Finance Committee language, which started that step down in 2027. It's not as good as the House language, which would have grandfathered in our average commercial rate. And just to give you some context, when the state-directed payment program, the MHAP program, really started in 2015, we were pulling in about $500 million out of that program. And when it blew up in 2023, many thanks to Governor Reeves, who instructed the division to look at some new studies and piggyback off of some things going on in Louisiana.
And Florida.
Yep. Blew up that program. We're now pulling in $1.5 billion because of the average commercial rate. So it's a big deal.
Yeah.
And stepping back down to Medicare is going to mean hundreds of millions of dollars in losses.
Yeah, so just I'll attempt to explain it. Correct me if I don't get this right. But essentially, you got three major payers. Commercial insurance, Medicare, Medicaid, and they don't all pay the same rates for the same services.
That's right.
In general, in that order, commercial pays more than Medicare, which pays more than Medicaid. And many providers, including hospitals, say we actually lose money every time we provide services that are claimed under Medicaid, reimbursed under Medicaid.
That's exactly
below cost.
That's exactly right. And so for years, we were under reimbursed for many, many patients. And so what happened in 2023 was really kind of a truing up of even what we had been under reimbursed in the past. And since then, again, thanks to Governor Reeves, we've been able to do things like open service lines, keep the doors open, hire a doctor, or do all of those sorts of things. So stepping back down to 110% of the Medicare rate, which is what we would be at because we're a non-expansion state.
Right.
Expansion states would be at 100% of the Medicare rate, is really going to hurt. We do get a runway which hospitals like. We like to know when things are going to happen, so at least we know we've got until 2028, and then we start stepping down. But it is going to mean hundreds of millions of dollars gone when we are up to $600 million a year in uncompensated care. We've climbed back up to $600 million.
Yeah, I didn't know that. It wasn't too long ago. It seemed like it was 400.
It is climbing, and it just continues to go that way.
Okay, so now let's explain this to the folks. Hospitals do receive some money from the federal government. It's called disproportionate share.
That's right.
Shorthand for it is DISH payments, is how it's referred to in the industry. And basically, it's when the federal government looks at your patient balance, your payer mix or non-payer mix, and they'll send you some money because you have an outsized amount of Medicare, Medicaid, or uninsured relative to commercial, right?
That's right.
Did I explain that correctly?
You're absolutely correct. And we get about $30-40 million from that. We will lose that beginning this year.
Okay.
Those will be stepped down. There'll be a big reduction there. The House language actually included some provisions that stepped that back to beginning in 2028, so we would have gotten a little more reprieve.
Okay.
So that's another smaller financial hit, is that DISH will begin to go away in September.
All right, so state-directed payments and then DISH payments possibly cut some holes in reimbursement to hospitals, your members. Let's talk about the changes in the provider tax and how that might affect Mississippi.
So less concerning.
Yeah.
And we are grateful for what the Senate did, which is grandfather in our rate.
Right.
So there's a 6% safe harbor in federal law. So federal law already dictates and puts limits on provider taxes. That limit is at 6%. We are about, couple tenths of a percentage point away from 6%, so we are almost to the limit.
Okay.
I think there are some questions about that language and the CMS regs and what will happen if we want to restructure that, for example. And we might need to restructure some things depending on what happens with this big, beautiful bill. We might need to change up some things, and hospitals are very used to that. But so we don't know exactly how that's going to be implemented, but we are very grateful for the grandfather clause. Non-expansion states, not non-expansion states, will see the beginning of a reduction.
They got a problem.
They've got a problem.
No doubt.
0.5% to 3.5% is where they end, so they're kind of getting hit from all sides.
Yeah, and so let's just explain this to the audience that might not be familiar with provider taxes. These are just taxes levied at the state level on healthcare providers. The state collects money from them, essentially, which gives states then more money to tap more federal Medicaid dollars.
Correct.
And so what the federal government's saying is, you guys are kind of gaming this thing here. You're getting money from the private sector to take more money from the federal government. And they're saying, and they're putting an end to that. Not an end to it, but they're restricting it somewhat and reducing it.
It's been interesting. I mean, we've heard terms like gimmick and scheme and things like that. I mean, I think the way we view it is we have voluntarily chosen to be taxed.
Yeah.
So that way the money does not come from the general fund. That way, that money that would have otherwise come from the general fund can go to fund other things in Mississippi that need to be funded. Hospitals are willing to tax themselves to the tune of about $475 million in order to pull down federal money that frankly, accounts for uncompensated care that we're required to provide.
Yeah.
I mean, that's part of the problem. I know you're a free market guy. I like the free market too, and we just don't exist in that.
I know.
I mean,
I agree with that.
I know. I've heard you talk about it before, but with EMTALA, we are required to screen and treat any patient that comes through to our ER, and that costs money. And a lot of Mississippians, a lot of working Mississippians, don't have insurance. I talked to a hospital CEO not too long ago who saw 11. He used these stats. He saw 11 people come through the ER. 9 of them were working, and there were people working in his community. It was Louisville, actually, a small community. So I mean, he knows these people. He knows that they have jobs and they're just trying to make ends meet, and they don't have insurance. And he's got to screen and treat them, and he wants to screen and treat them because they're people that go to church with him and shop at the grocery store and whatever else. So.
And many workers in Mississippi, we don't have a lot of large companies that typically offer health insurance as part of their compensation and their employment package. There's lots of small, mid-sized businesses that find it cost prohibitive.
That's right.
And just don't offer it, so they're on their own, essentially. So they're working, but they don't have access to commercial insurance through their employer.
That's right.
Which is where most people in this country get their insurance.
That's right. I've never experienced not having insurance. I can't imagine how taxing that would be on a family, and it's draining hospitals. I mean, it really is. It's a very difficult situation that we're in.
Yeah, it is.
Which is part of the reason why the exchange has been so important.
Yeah, we'll get to that in the next segment. We've got Leah Smith, General Counsel and Vice President for Policy and Advocacy for the Mississippi Hospital Association in the Element Well studio. We're coming right back. And Leah Smith, General Counsel, Vice President for Policy and Advocacy for the Mississippi Hospital Association, is our guest in the Element Well studio. So the House leadership just announced after the Senate, we just learned, passed the big, beautiful bill. Rhino, you told us there were 3 nays: Collins, Paul, and Johnson? Is that right? Oh, Tillis, right. Pardon me. Johnson, he came around. How could I forget Tillis? Because he's been all over the news having opposed the legislation, and the president lit into him, and then he said, okay, I'm not running again.
That's right. That's right.
He kind of solved that problem. All right, but we're just looking at now the announcement coming from the House side, Leah, is that we think we got a deal that they can get through. That's what House leadership, that was just put up on the screen here. So
I'll tell you what, this is my first time on SuperTalk, and I came at the exact wrong time because the bill is changing like every 5 minutes. So
I know, and you and I were talking
working with it.
I know, but this something that's important in Mississippi is a rural hospital stabilization fund. Explain that. We're not sure where that landed right now. There was a difference in the House and the Senate version. There was some discussion about that. I'm not sure if the parliamentarian had to get involved in that one or not.
So
but talk about that.
I would love to, and I'll talk about the parliamentarian separately. That's been so interesting to learn about the bird rule and the bird bath and all of that sort of stuff. But with this rural hospital transformation fund, we were so glad to see it included. It's so important for a state like Mississippi that pretty much all of our hospitals are considered rural in one way or another. And will benefit. Many of them will benefit from this fund. The major problem with it, the House I think recommended $15 billion. The Senate landed on $25 billion when they got through the Senate Finance Committee. I had read 30 minutes ago that in an effort to appease Senator Collins, they were moving to $50 billion. Now, maybe that didn't get through, and that's where the no vote came from. So I'm not really sure. But the major issue is it's a one-off program. So, I mean, the way that it's going to work under the $25 billion scenario is it's $10 billion in 2028, $10 billion in 2029, $2 billion the next 2 years, and then $1 billion. And then it's gone. And I think that this is something that our CEO, Richard Robertson, has talked about with you before. But one of the challenges, like any business, is you have to be able to plan.
Sure.
And I think hospitals keep getting the rules changed. There's a new program. There's an old the program's going away. The program's coming online in 5 years. There's no way to hire a doctor and say, all right, we're going to keep you for 4 years, and then in 2032 or whatever, we're going to have to let you go.
Yeah.
I mean, that's not a good business practice. And so I think what we have tried to advocate for is pick a program and let's just stay with it. Let's just stay with whatever we're going to do, and that way we know what we need to budget for. And the off ramps are helpful. Knowing these extended time frames are helpful, but we have to be able to plan, and that just hasn't been that has not been in the cards for hospitals across the nation, really. But Mississippi.
The House proposed $15 billion.
Okay.
The Senate amended that to 25.
Okay.
Over 5 years.
That's right.
Susan Collins, who, Rhino, you just informed us was a nay vote, she wanted $100 billion.
Okay.
Is what she wanted. So I'm thinking that maybe she opposed the bill because it didn't get to the $100 billion that she wanted.
I think that's probably true.
Yeah.
I did read a stat this morning from the National Rural Health Association. I've not vetted it, but it said that we're only going to make up 43% of what rural hospitals are going to lose under the bill in Mississippi with the $25 billion. So, with the state-directed payment losses, with the dish payment losses, with the health insurance exchange issues.
Let's talk about that. Keep going, but let's get to that.
Yeah, I just, all of those things collectively are going to be a really big hit over time. Okay. And that's the issue. But look, grateful for it. Glad it made it in there. The conversations really started about a week ago. We've been sending correspondence almost daily to staffers and our senators, and we got word that there might be a fund, and we were very grateful for it. So we're glad it's in there.
So how do the hospitals tap that fund? How do they qualify for that? What's the process? I'm sure it's arduous at best.
Well, it probably is, and that was one of our concerns, is that many of these sort of one-off programs have a lot of hitches, and we're just going to have to see how that shakes down in regulations. I do know the way that it's going to be allocated is half is going to be allocated to the states just equally, and then half is going to be based on CMS discretion. We are not big fans of that. We would like for Congress to say what's rule, so that way we know that Mississippi is going to be included, because how could almost all of our hospitals not be included?
Right.
And so we would prefer not to give that to the agency discretion, but right now half the fund is left to the agency. So we don't know details other than that.
Okay. So we were talking about EMTALA. Of course, I always remind the audience this was passed and signed into law by Ronald Reagan. A lot of people don't realize that.
That's right.
The Emergency Medical and Labor Treatment Act. I think I got it right.
Yeah.
The acronym.
Yeah.
Bottom line is, if you show up at the ER and there's some sort of urgent medical condition, or you're in labor, the hospital is required to stabilize the patient, essentially.
And transfer them or do whatever they need to do.
Yeah, and back in the old days, I've researched this extensively. They dump them on the public county hospitals where the care, honestly, was subpar.
Right.
But they'd get them out of the better private hospitals. And that's a requirement if they, I believe, participate in Medicare, if I'm not mistaken.
That's correct.
So to stay in the program. So it's the only industry I know of where you're required to deliver services to someone even if they can't pay.
That's right.
There's really none other. So on that basis, I've said it many times on the show, we really don't have a free market in healthcare until an ER could say, oh, can you pay? Well, if you can't pay, I'm sorry, we can't take care of you.
That's right.
That doesn't happen in this country. Doesn't happen in Mississippi.
That's exactly right. And I would say I've worked with the hospitals for 5 or 6 years in my previous role with the Lieutenant Governor, but I've worked with them so much more closely, and I can definitively say they want to care for people.
Sure.
I mean, it's not as if when people walk into an ER, they want to leave them desolate. They want to help them. They also want to keep the hospital open. And they want to keep service lines that are needed in the community open, and they want to recruit a new physician to care for more. They want to do all these things. So it's very difficult, and it is not a free market, and that's why things like CON still exist, which we might talk about later, but and will likely come up again next year, and we are in favor of reform. But in order to get rid of things like that, we also have to exist in a true free market, because otherwise we don't have the payer mix that supports keeping a business open that's underwater.
I understand.
And in 2023, we really saw a situation. I mean, I was actually on the campaign trail in 2023. So imagine being on the campaign trail and having to answer questions about hospitals that are failing. Thank goodness that was remedied in the fall with enhanced MHAP, and that's all good. But on the campaign trail, it was hard to answer those questions. How are we going to save the hospital in my community? And hospitals are changing. I have been so impressed with how open our hospitals are to talking about their business models, or how they can work together, or how we can share information and reduce costs. But we're the lowest cost in the nation. I mean, that is the truth. We are the lowest cost in the nation, and we're about mid-range related to care. So we are providing excellent care at a very low cost. It's a revenue issue.
And so the reason I brought this EMTALA issue up, and you did a great job of expanding on that, was because of what you pointed out earlier in our discussion, that just the large number of uninsured
That's right.
In our population. And it's likely that number is going to be boosted with these reforms that are coming out of the bill. One of those reforms that would affect Mississippi, of course, is that the enhanced subsidies in the ACA marketplaces, the exchanges, those expire at the end of this year. I just researched this a couple of weeks ago. I was a little shocked to learn that the ACA enrollment in Mississippi, just as it has across the country, is increased substantially to like over 300,000.
Yes.
330,000, I think, is the last figure I saw, of which 270,000 received some sort of credits, of subsidies from the federal government.
That's right.
For that coverage. But it is expected that many will drop their coverage because they'll have to come out of pocket with more when the enhanced subsidies are terminated or expired at the end of the year. And that could, again, bolster our uninsured population, which could be a problem for hospitals, could it not?
Absolutely. It's a huge problem. I mean, they're not going to be able to pay. And if they have the insurance, it's junk insurance because they can't afford the out-of-pocket cost.
We got a break right now. If you can hang around, we'll continue this discussion.
Happy to.
All right. We got Leah Smith, General Counsel, Vice President for Policy and Advocacy with the Mississippi Hospital Association. Studio. So we went to break, Leah. We were just talking about how we might see the roles of uninsured shrink from losing the enhanced subsidies in the Affordable Care Act. Now, the latest estimates by the CBO are that some 12 million or so are going to lose coverage from all the various reforms.
That's right.
Medicaid, Medicare, and, of course, the ACA exchanges. But Mississippi, there was a time period where kind of 100,000 was sort of the average per year. But with the enhanced subsidies, and I think more insurers participating in our exchanges, and probably more importantly, and let you talk about this, more providers are now in network and accepting, right, the coverage sold on the exchanges. For a while, yeah, you could get coverage, but you had to pay out of pocket before you left the doctor's office or the hospital or have some other arrangement and then get reimbursed.
It was essentially junk insurance.
Yeah, it was terrible.
And so providers didn't want to participate.
Well, that's improved a lot.
It is totally improved, and I think the pandemic really had a huge impact in that. I mean, not only did the subsidies occur because of the pandemic, but also I think people got really interested in their health care.
Yeah.
And they got interested in the ways that they could pay for their health care. And this came along. I think government started paying attention to the exchange.
Right. Yep.
That's why we saw so much talk of it in 2024 when we were going through some of the Medicaid expansion debates. I mean, the exchange was a huge part of that. The subsidies were a huge part of that. So I think letting it go is going to be hard on Mississippians. It's going to be hard on hospitals. 24
million nationally enrolled, last I checked at KFF, in the exchanges. Wasn't too long ago, it was 10 million.
That's right. That's
like
right.
7-8 years ago, it was 10 million.
Which I think is shows that people want to take care of their health care. None of us want to go to the doctor and not be able to afford it. Yeah. I mean, I've talked to people who have been either on Medicaid and kind of been looked at a different way, or have not been able to pay for their health care. And it's an embarrassing, it's a thing that you don't want to happen to you when you're trying to take care of things in your life. So I do think that there are working people in Mississippi that want to find a way, even if they're cost sharing, even if the cost sharing goes up a little bit.
Which is planned in the bill, right? For Medicaid.
That's right, for Medicaid. But, on the subsidies, I'm wondering if there would be room for, taking down, for example, you were talking about 400% of the federal poverty level. That might be too high. Yeah. That may be too high for subsidies. Maybe we take that down a little bit. Maybe we increase cost sharing a little bit. But to just do away with them, I think would be really problematic, not only for hospitals, but for patients.
Yeah, and that's something else, the cost sharing subsidies that the president has sought to reduce. And then what happened is all the insurers sort of restructured their plans around that so that there would be less out-of-pocket costs, right?
That's right.
So they could get premium reimbursement.
That's right.
Yeah.
So it's a big change. It's a big change.
All right, so what are hospitals doing? I mean, you represent the Hospital Association. What are you guys doing to kind of prepare for all these changes? Because it's a lot, as we've talked about here.
It is a lot. I think that we are going to have to see what ultimately passes, which looks like it could be fairly quickly here, which surprises me, actually. I thought there would be more maybe debate in the House. It's going to take some time, maybe a year, to roll out CMS regulations on all of these things.
Got to code it.
So we're going to have to, that's exactly right. So we're going to have to figure out, what that means, for example, in terms of our provider tax. Can we restructure?
Yeah.
Are there things we can do even within that limit that we're going to be grandfathered in at? And then our hospitals are very aware, even with the state-directed payment program enhancement that happened in 2023.
Yeah.
They were very aware that could go away at any moment. So they have.
But isn't it? I don't mean to interrupt you, Leah, but isn't it fair to say that maybe some hospitals, particularly our rural hospitals, were on the edge and may not have survived without that?
100%. I mean, we had 3 or 4, and this is just from knowing health policy, being on the campaign and not being with MHA. There were 3 or 4 hospitals that were on the brink of shutting down. Even our larger systems were struggling. Service lines were closing. We had other big issues like Greenwood and places like that that were really struggling, and they were really helped out by the enhanced MHAP. So and they're doing fine. Hospitals are doing okay right now in Mississippi, and they're adding where they need to. They're adding a service line. They're partnering together. I just saw not too long ago that Tyler Holmes, for example, has partnered with Baptist to add cardiovascular services. So that is one thing they're doing. They're figuring out how to cut costs, how to work together to provide services, share workforce, share information. That has been a really big thing at MHA. We are trying to figure out how to leverage AI, health information, so that we can be efficient in transfers, for example. So that we can identify, for example, patients who are going to the ER more than 4 times a year and redirect them somewhere else, so that they are getting general health care and they're not showing up in the ER for a flu situation. And we can do all of these things with technology. We're building a lot of that out. But I think that hospitals have always known that the average commercial rate was fragile, that it could go away. And I think for that reason, they have planned accordingly. They haven't been spending, or acquiring or trying to add where they might have to completely cut in a couple of years. But still, it's a blow, and it's going to be hard on hospitals. What
are you going to be talking to the legislature about this coming session?
So, I think the payer mix is always at issue. There might be some other creative ways we could deal with that. And I've had some broad conversations with Chairman Creekmore about this and Chairman Bryan. I think that CON is back on the table. I think we'll probably see a bill kind of like what was vetoed this year because of the one issue with one hospital. We would like to see that bill go a little bit further. We liked the House version that allowed hospitals to do things like dialysis. If we are going to require hospitals to see and treat patients that can't pay, we should also allow hospitals to perform services that typically do pay. And not only that, but it's good for patients to have a choice. If they want to stay in their hospital with their other providers to receive that treatment, then they should be allowed to do that. And right now, they can't. So
what's the official position of MHA on CON reform in general? I mean, are you for complete repeal of all CON or limited? Tell us about that.
So with the payer mix issues, we feel like CONs need to remain intact in some form because we don't have the benefit of having all patients that pay. But having said that, we believe in reforms, and we worked closely with Chairman Creekmore and Chairman Bryan on that bill. We worked closely with Kevin Blackwell. For example, the CapEx expenditure thresholds are too low. I mean, right now it's $1.5 million on equipment to
pave a parking lot. I mean, that's ridiculous.
Or buy a piece of healthcare equipment. We have far exceeded $1.5 million. We should have had a growth rate in there. We do to some extent, but it has been applied in sort of a wonky way. And so we believe that we need to raise that and add a growth rate for clinical, non-clinical, and for medical equipment. We are fully on board. We also believe in a level level playing field.
Okay.
So everybody needs to play by the same rules, and right now we don't necessarily
Okay, so
have
the
that.
House bill you guys were in support of.
Oh, yeah.
That came out this year.
We in fact liked the original version of the House bill that kind of went a little bit
had
further.
further reform. Yeah,
Yep.
exactly.
Yep. And
Well, that's going to be a big topic again in this session.
I
And
think it will. Talk to Chairman Creekmore about it the other day.
and perhaps it will include even additional reform as well.
You never know.
Okay. But your members are okay with that.
We are always willing to look at reform. We know that things don't need to remain stagnant.
Well, a whole lot of folks in white coats show up, as you know, in those committee meetings that oppose it.
You would be surprised. I mean, we really didn't have a lot of opposition to the bill that was at issue this year.
Okay.
And I think that's just because we all worked it out and talked about it in advance, and we knew that there wasn't going to be wholesale repeal because we're still dealing with that payer mix issue. And we know that
We'll work on that.
It might be on the table at some point.
But Senator Bryan doesn't seem to be in favor of anything.
You know what? He was fully in favor of the bill that he and Sam Creekmore negotiated together.
Yeah.
And he was great about it. I think he understands that. I'm not going to speak for him, but I think we all understand that a threshold of $1.5 million, for example, on medical equipment is going to change over
That's
time.
a no-brainer.
It has to.
Yeah,
That's right.
That's an easy one, though.
That's right.
But I think we can go further than that. Don't you?
We will definitely be working on it.
We'll keep talking about that. I appreciate you coming in, Leah. Enjoyed it. Thank you a lot.
Me too.
Yeah. Leah Smith, General Counsel and Vice President for Policy and Advocacy for the Mississippi Hospital Association. She's been our guest in the Element Well studio, another segment in this